Yes.
Okay. Thank you so much. This is Tim Henrich. He is, are you a clinician?
I'm a clinician researcher.
Yes, he's a clinician researcher up at Harvard.
That's correct, yes.
And he's done some really interesting research that is still in process, but I thought it might be a good opportunity for people to just kind of meet a researcher and hear about his thought processes, hear about this really interesting project that he's still working on, and just a little bit about his background. So, where are you from?
I'm from Boston, Massachusetts.
And there we are. And how did you get interested in medical research?
So I went to medical school later in the career. This is my second career already. But wanted to do something involving science, but also involving people, where I could use science to directly help individuals and also stay in contact with people and have social interactions with them at the same time. So I thought medicine was the perfect way to do that, where you certainly make science and kind of social outreach and feeling like you're contributing to society, but at the same time pursue a scientific kind of research career. So that's what got me into this. And actually HIV specifically was, as a medical student, I followed a patient at school that over 4 years of my time, and he was in and out of prison at the time as well, with HIV, and it was a longitudinal elective for me to learn about how to take care of patients over the longer term, and I just became more and more involved and interested in helping those with HIV during that time as a medical student. And I just kind of grew as I went on my further training.
What was your first career?
So I was actually an English teacher in Japan. Completely unrelated.
Knew it! I called it, you guys. All right, so what can you tell me a little bit about why you decided to do this research project, and then what was, just to talk a little bit about the research project that you were talking about releasing data on at this conference.
Sure. So I think this all started about 2007, 2008, when the Berlin patient, or Timothy Ray Brown's data was first written. And in over 30 years of the epidemic here in the United States, there's never been one sustainable functional cure for HIV. There are patients that can control their disease for a long period of time without progressing, probably because of genetic or other viral factors involved. But this is really the first time that anybody was really cured by an intervention that we did, that physicians or that the scientific committee actually did to a patient. So that was, although it's only been one and is currently the only one, it was also extremely exciting because it proved that no matter how difficult it was, you actually could cure HIV. You could get rid of, or at least make HIV so it wouldn't come back and be a problem in the body.
Proof of concept.
Proof of concept, exactly.
Major thing.
It's one patient. It wasn't a practical modality for sure, but it was a proof of concept. And I think that there were people in the early epidemic before treatment who were looking at ideas about cure, even radical things about cure, because people were dying and there was nothing that we could do. And once treatment came along, I think obviously interest in the cure waned a little bit because the treatment became less toxic. It became really good, and treatment is fantastic, and it's been amazing worldwide for what it can do for people living with HIV, and rightfully so. It's a fantastic. And when I first started in HIV research, it was looking at drug resistance and kind of novel drugs that were being developed for studying HIV, because that's really what we're controlling the epidemic with, or attempting to. It depends on what area it's in.
You should be louder because it's a tiny little mic on that little.
I can also enhance the audio a bit, but yeah.
Okay.
So, but it is proof of concept, and I think ever since that time there's been this resurgence in interest in, well, now that we've proved the concept, how do we go about doing it in an affordable and or scalable way to more individuals that would be cost effective and safe for patients in comparison to treatment. So that's the big challenge, and it's a huge challenge.
Yep.
So
we think so too. I mean, it's one thing the research community and the activist community has in common when it comes to a cure, like big goal, big goal.
Exactly, yeah. But it got me interested. I mean, I certainly remember reading the article when it first came out, thinking this is incredible, this is fantastic. And the fact that it's sustained now for almost 5 years off therapy has just been really great. So, so that's where we became interested in looking at similar types of modalities, for example, bone marrow transplant for people with HIV that also have cancer of the blood. Those are people who need bone marrow transplants. To see that maybe you can use this modality to learn more about how HIV can be cured, even in the setting when those transplants do not include cells that are not able to be infected by HIV by certain strains, like it was the case in Timothy Brown's case. So that's kind of what led us to thinking about our project and how to do that.
And can you talk about what the project actually was?
So we did. We're actually following, it's an observational study right now, but we're following a group of HIV positive patients that also have malignancies or cancers of the blood, and are undergoing or will be undergoing allogeneic stem cell transplant, which means they get cells from someone else. There are two types of transplants. There's one where you get high-dose chemotherapy and then you get your own cells back. But that's not shown to reduce, or it's not shown to get rid of HIV. HIV persists after that because the cells that are reinfused are your own, and those can often harbor HIV, genetic material from HIV that gets passed along. So it looks like the chemotherapy itself that they give for the transplant is not what's causing that reduction. But allogeneic stem cell transplant means that you get donor cells from somebody else. So you find a donor that's genetically similar to you enough that your body will accept those cells, and you have chemotherapy up front that reduces your own cell, your own bone marrow, your own peripheral blood production, and then you replace that with this other person's cells. And what's interesting is that we were very interested to see when you replace those cells from an HIV negative donor, if you keep them on antiretroviral therapy, does it protect those cells from becoming infected? It sounds almost intuitive. I think it was intuitive that we thought, well, we think it does. But again, this really hadn't been shown directly that you can actually protect these new cells from coming in. So that's one of the things that we wanted to look at. And we certainly, so two of the patients that we have long-term follow-up data now underwent these allogeneic stem cell transplant or bone marrow transplant. We kind of interchange those words. Because sometimes they take the stem cells from the peripheral blood, not necessarily just from the bone marrow. So it's on.
So just to kind of recap, one of the goals of this study, which was two people, was if we give...
Although we have more enrolling, obviously, as we go forward.
Right. If we give someone healthy cells, can we sort of protect them by giving them in the context of AIDS treatment? And is that going to keep them from getting infected as they're infused into the patient?
So it seems, at least from our...
sort of guardian AIDS treatment, keep those cells safe as they're being infused.
It seems, at least from our preliminary data that we presented here, that they are being protected. So it's almost like kind of prep. For the cells. Rather than prepping a person, you're prepping the cells that go into the person. And what we're seeing is that as those cells take over, in the patients that we have, it takes about several months at least for these donor cells from other people to really start to repopulate and replace the cells in the initial HIV-infected individual. And it sees, at least from what we can see, is as those cells engraft, which means as they kind of take over and become the cells, take hold and become the blood cells in these patients, that they're protected from becoming infected by HIV. We don't see evidence, at least from the detection assays, at least the assays that we're using, we don't see evidence of HIV in these cells or in the plasma, kind of the peripheral circulating blood, viral particles. So I think it's exciting because we can potentially protect all these new cells from becoming infected. Now the big question, I think, is have all these cells completely replaced the initial infected cells that still harbor HIV. HIV can hide in cells, so rather than just being a virus that floats around, it can take its genetic material and integrate it into a cell and then just basically lay resting for a very, very, very long period of time.
Can I just interrupt? Can you actually just give like a quick, like 2-sentence explanation or whatever of exactly what your study was?
Oh, sure.
You know what I mean? Just so people.
Yep.
I mean, we're going to have some additional information, but just so people have the plot.
Sure. So we're interested in looking at HIV patients who are undergoing allogeneic stem cell transplant with cells from another donor, and we're interested in looking at what happens to the total amount of HIV, either in the peripheral blood or in the body, after the transplant. And this is not just the plasma virus, we're interested in that for sure, but also virus that's integrated into cells or virus that is hiding, using its genetic material to hide into the body. And what we're very interested in looking with the study is to say, what are the effects of both the chemotherapy for the transplant, the engraftment of these donor cells, or the replacement of host by donor cells, and also in the setting of antiretroviral therapy, what happens to the HIV reservoir? Does it go down? Does it change? Does it not change? Does it become eliminated? Do you get it low enough for the fact when you take off intraarterial therapy, will the virus come back? So those are the questions that we're interested in asking with this question. Now it's different from the Berlin patient in that these patients are not necessarily being transplanted with cells that lack the capacity of certain strains of HIV to enter.
And why did you not pick someone, why did you not use donors like the Berlin patient's donors who were born immune to AIDS?
Sure, so it's actually a few reasons. We're not actually transplanting the patients ourselves. We're following along longitudinally with patients who would be getting transplanted for their malignancies anyway.
So it's not up to you anyway?
It's not up to me to decide which cells go in. Now that said, it's quite rare to find this genetic mutation in the population that would also match the donor. So when you look for a bone marrow transplant recipient, you have to find cells that are genetically similar to the person going to be receiving those cells. But then you have to add on, which is hard enough already, but then you take that and then add on this rare mutation, and it's much more rare in certain populations. It's much more prevalent, for example, in the white Caucasian population. So it's very difficult to not only match it for your own genetics, but then also specifically for this co-receptor. And that's, I think, the reason why most of the transplants so far have not been done by this. Now that said, people are interested in looking at finding donors that have this mutation.
Does Harvard keep a database of those? I know City of Hope, everybody who comes in with cancer at City of Hope Medical Center in Suarte, California, they test them for CCR5. Right. They test them to see if they were naturally born immune to AIDS. So then you have this database of people you can use in research if they're willing.
CCR5 is interesting because HIV can use mainly two co-receptors. So it needs CD4, which is on the outside of cells, one of these receptors, but it also needs either CCR5 or CXCR4. Sometimes it can use both. Oftentimes it can use both. So the question is, if the person has a virus strain that can also use this other co-receptor, would those patients have the same response as the Berlin patient? It was interesting, they showed some data at the Cure Symposium that showed that perhaps the virus from the Berlin patient was not predominantly used CCR5. So the virus preferred to use CCR5, and that was the reason that, one of the main reasons that he's been cured. So it's unclear about other strains of HIV, and as people progress in HIV, we see more and more of the virus being able to use this other co-receptor. So the question is, one of the questions that I have is, in patients that are transplanted with this dysfunctional CCR5, if they have virus that's able to use CXCR4, will it actually work? I don't know. It's interesting that when you're acutely infected by HIV, so when someone is first infected, almost all of those viruses tend to use CCR5. So it's potential that it may work because you're, if you think about it, an acute infection. But again, if they already have a lot of virus in their body that's able to use this other co-receptor, then it may not be as effective. So it's unclear.
So you decided not to use one of those donors because it was you were following people who were
right. So it's observational.
Exactly. That wasn't your call. Really.
It was not my call. Okay. Right. No.
And what is your follow-up research? So to give a bottom line, what does this mean to people with AIDS, if anything, or maybe no? I mean, there may be nothing definitive, or maybe there is. And then, what would be your follow-up? What research are you then going to be doing?
I think the big question is have we anything that's practical for a majority of people living with HIV or AIDS? And I think the answer to that right now is no.
No, but I mean, like, what does this imply?
Imply. I see.
But it's not like something you can buy in the drugstore. But what does this imply for people with AIDS, if anything, potentially, And then what's your follow-up research going to be to continue research?
I think this is an interesting proof of concept that, again, that we're able to see changes in this reservoir of HIV that continues to persist on antiretroviral therapy, and that we now have modalities where we're coming up with proof of concept where we can actually really make a dent in that reservoir, because that's going to be very important in curing HIV, is to really get rid of this residual HIV that persists despite.
Are you talking about verinostat, or are you talking?
Well, there's different modalities. People are looking at, for example, verinostat, or ways of taking those cells that harbor HIV and activating them so they start expressing, and then you can hopefully clear out the cells and purge the reservoir that way. So you're purging it by activating. Other people are looking at gene therapy, actually in the body. Manipulating the CCR5 gene, for example, and that's another very interesting modality that people are looking at as well. So both of these are really interesting scientifically because they would be considered, I think, radical, from 10 to 15 years ago to do gene therapy or to activate cells when the paradigm had been to try to reduce as much replication and activation as possible.
That's a good point, yeah.
So, but I think it's just a change in thinking of as people are getting more creative, and there's a lot more creative thinking now on how you can do this. And I think it's interesting because this type of work could be applied not just to HIV but to other infections and other diseases. So it's certainly very exciting to be a new person involved in this.
And verinostat is a drug that was originally approved by the FDA for skin cancer or something, I think. Is that the skin cancer one?
I don't remember.
Yeah, I mean, so we're actually taking a page from cancer research in our efforts to cure AIDS, which is cool.
He also mentioned something in his presentation at the symposium about chemotherapy for viral reservoirs. Did I mishear that?
So chemotherapy alone, so for example, chemotherapy for cancer, the chemotherapy they use before transplant, will kill a substantial amount of the blood cells in the body. And so there was a thought that maybe just using this type of chemotherapy could reduce the number of cells that had HIV. The problem with that is that patients that get chemotherapy for cancer or these autologous stem cell transplants where they get high-dose chemotherapy followed by reinfusion of their own cells, they still have HIV persisting after that time. Now there hasn't been a thorough longitudinal pre and after therapy study, and actually we're looking at these patients as well. So we're looking at patients that are getting chemotherapy for cancers without transplant and also in folks that are getting autologous stem cell transplants. So that's also a larger part of our study that we haven't presented data yet, but we're certainly interested in looking at what the effect of the chemotherapy, although I have a feeling that it's a minor player compared to the actual infusing HIV negative cells and protecting them in the setting of antiretroviral therapy.
When you did your stem cell, did you were you one of the people that used a lower dose of,
yes.
Can you talk about that?
Yes.
The difference between the Berlin patients conditioning and what conditioning is and what you
Sure. Again, so this was protocol as per the transplant protocol, so we didn't have...
You followed along.
But it turned out to be extremely interesting scientifically from our standpoint, so we were very lucky, I think, to have these patients treated as they were. So with bone marrow transplants, there are different ways of doing them. So it depends on the type of cancer, depends on the age of the patient, the relative health of the patient, etc. And you can you can take two approaches, and one is this what we as a conditioning. And conditioning basically means what kind of therapy, either chemotherapy or other therapy, that you can give up front to initially ablate someone's bone marrow and their blood cells.
Ablate meaning to
kill the bone marrow. So when you infuse the new cells, they'll take over and reseed the bone marrow rather than the old cells coming back. So traditionally, these use very high dose, very toxic chemotherapy regimens. And they would also use body irradiation. So Timothy Brown actually underwent 2 transplants fairly close together, and both times had total body irradiation, so had radiation to the entire body, in addition to some immune therapy to directly attack lymphocytes, which are a type of white blood cell that harbor HIV, although that's not why he received it. It's for the transplant. And then engrafted or had the donor cells take over. Our patients were a little bit different because they do not get total body radiation. They don't get radiated. They don't have the immune therapy. They have a slightly more gentle course of chemotherapy before. And then what's interesting about these patients is they have a mixture of their own cells and the donor cells for up to 6 to 8 months after transplant. They can intermingle because they don't get this toxic upfront therapy. That said, because they don't get such upfront toxicity, it's actually it's a little bit easier on the patient. So, for example, it was easier for them to continue taking their medications, their
that's right. So
HIV medications.
So once again, the plot is these people did not. You followed 2 patients, and you're following more. But these 2 patients were given stem cell transplants with taking their AIDS drugs, and those AIDS drugs protected the uninfected cells that came in. Okay. What is the so there's been a point of fact that the type of conditioning or preparation for the whole procedure that the Berlin patient endured has a 1/3 chance of mortality overall, although in some labs, like John Zaya's in City of Hope again, it's like 10%. What is the type, which is also kind of interesting, not that you want a 10% chance of mortality, but I'm just saying it's 30% is not set in stone. What is the chance of mortality given the lighter conditioning regimen that the stem cell recipients at Harvard had?
So the number that the oncologists use offhand for this type of procedure, this reduced intensive conditioning, is a 2-year mortality of approximately 15%.
Well, still bad.
Yes, it's still not.
I mean, that's surprising.
It's better, but it's still a stem cell transplant.
And that's from the transplant and not from the cancer?
Well, that's. It's hard to parse those out because all those getting transplants also have the cancer. So whether that's because they have recurrence of the cancer, that's certainly the case in some transplant. Is it because they have an infection because of the transplant? That certainly is the case in some. So it's hard to parse out exactly what contributes, and I don't know the literature too well, as I'm not an oncologist, but certainly the all-come mortality in about 2 years is around 15%. Which, and for many of these people, if they don't get a transplant,
the
mortality,
it's terrible. Yeah,
right,
I mean, that's
terrible. So for them, it's actually it's pretty good odds for going in. It's all relative, I guess.
Yes, highly relative. Yeah. So now,
in healthy people, we don't know because we don't transplant healthy patients.
That's right.
So would it be less?
Point.
It's potentially would be much less. But again, you still have. So that's come up. If for example, if people did want to transplant with cells that were CCR5 defective, would they have a less than 15 or 30%?
Deletion.
Deletion.
Really, defective is a little harsh considering it's an up thing, you know.
You're right.
Being silly,
actually, I should rephrase because it's a genetic variant that's found in the healthy population. So let me rephrase it. It's not a defect. It's a variation in the gene and how it's expressed on different individuals. So and it's actually quite common in certain populations.
So you're going to follow more of these patients, and how many more are you following right now?
So right now we've enrolled 2 more patients. So we have a total of 4 that we're following now, and obviously we're collecting as many as we can find at this point. Now the main challenge to this type of research is that there aren't many of these patients around because by the time that someone gets to allogeneic stem cell transplant, they've failed the first-line chemotherapy, probably second-line salvage chemotherapy, and many of the patients in our center are an autologous stem cell transplant. So they've already had 1, 2, 3 lines of therapy. So by the time that they get to this point, it's really the last kind of therapeutic modality that they're offered. So fortunately, the chemotherapy is getting better. So people are getting their cancer is being cured or at least put into remission by the initial first and second line therapies.
So is there so basically what might be any practical down the line if this were to be turned into a therapy? Would it be the idea that we could infuse I don't know, is there any potential practical?
Well,
potentially.
Potentially not. Yeah, I think for a vast majority of people with HIV or AIDS, this is not a practical. And for the reasons that bone marrow transplants are dangerous, as you mentioned, it's very expensive to do. So, especially in a resource-limited setting, this would be very difficult to do, at least practically in the near future. And we don't really fully understand. We really have an N of 1 so far, which is Timothy Brown on the efficacy. So hopefully we can add to that body of literature in the future. But certainly we don't have a lot of experience doing this. So it's hard to scale. Hard to imagine scaling this up to be. But I think it's more interesting in really learning about the basic science of how HIV persists, and then applying that knowledge that you gain to other slightly more scalable technologies, if that makes sense.
Well, I guess the AIDS Policy Project would say that what is scalable, what is impossible to scale right now, in 5 years might be a different story.
Right.
And in fact, we've been working with people who are like CERN, the California Institute for Regenerative Medicine, that funds stem cell research that's somehow connected to California or has researchers in California. They actually have partners that do this kind of work. And this kind of research all over the world, in Brazil, in India, in China, and so we'll have to see what we end up actually trying to scale. I guess our strong feeling is not to take anything off the table yet. It's early days.
I agree. I think we're just starting to learn about curative strategies, and as a scientist and as a physician who treats people with HIV, this is extremely exciting, and it's actually reinvigorated my own interest in science and medicine. of course, when you're a junior and starting to try to get funding, it's a bit of a challenge to try to get going. But I think just because it's so young but has such a really interesting potential, it's been very, very exciting to be a junior person kind of working, kind of getting into this field now while it's fresh. So yeah, very exciting.
Is there something else, or is there another researcher, and even in a different field, that has been here that you thought was work you found really interesting? And is there another, just anything that you've seen at the conference that you thought was particularly interesting, or what has caught your eye? First, it could be extremely off topic, which is just a curious thing to hear.
Well, completely biased. I thought the curative sessions were very, very interesting. And I'm totally biased, obviously. There was a workshop, as you know, before the conference that highlighted some of the scientists that were dealing, and not just scientists, but advocates and whatnot. And that was a really, really interesting session to hear what was going on. And what I took home from this is that there's so much more understanding of how HIV hides, where it hides, and maybe leading into the main meeting, that if you treat people early, that perhaps this is a good thing. And I think that everything that I've seen so far at this meeting is that earlier treatment, whether an acute infection, if you can treat someone right when they're infected, does this help lower their reservoir? That's a really interesting question, and that's some interesting data that's coming out on that too. So
there's like this whole public health thing in Boston about trying to get emergency room doctors to be able to recognize when people are having primary infection, so that they can nail them with drugs. And also that means that those people who might be on some sort of like bender realize that they need to start using condoms right that moment, because apparently a lot of times people who are transmitting HIV, it's sometimes because they are having some sort of, they're depressed or there's something happening and they're on some sort of binge. They become very sick from HIV. They end up in the ER, and if somebody lets them know that they may have HIV, then they can stop that, and they will not continue to infect 2 more people or something. So there's actually.
So from about like 15 seconds ago, 30 seconds ago.
Okay. We're finished, or what?
No, I mean, you have to repeat like.
Oh, 15 seconds ago. Okay.
Yeah, like.
Okay.
Be like a minute ago now.
Okay. So basically, I was going to say that Boston has there's a public health effort in Boston to train clinicians in ERs so that they catch people. It's very difficult to do, to figure out who actually has who's just been infected with HIV, so they can get them on AIDS drugs, and then they can also let them know so they can protect themselves and other people. And if we're able to do that, it's seeming like the data at this conference is showing that if you can get people on treatment at that point, that in many ways there's a better chance for their HIV infection going forward to be sort of contained, and it's almost smaller than it would otherwise have been. And maybe perhaps in the future more highly speculatively easier to cure.
Right. I mean, especially if I think that's recognizing early infection is very important. It's amazing that even in our own hospitals, the Harvard hospitals, when we teach residents and we teach fellows and medical students about primary HIV disease, we're still seeing patients. The problem is that it looks like a lot of acute viral syndrome, so flu or
everything looks like that.
So what we're trying to instill into our clinicians is that when you think acute viral syndrome, think HIV. You should always think of that, because and what we're learning now at this meeting and from other work that's been ongoing, that probably the earlier you start treatment, the better people do, most likely. It seems like it may be cost effective in certain situations as well. Certainly treating reduces transmission, and if the data do pan out that treating an acute infection actually reduces the reservoir, will that make it easier to cure and or control disease in the future? It's possible, and that would be very exciting if that does pan out. So I think more work has been done. It needs to be done, but we have that initial very, very interesting data that's coming out that should be very interesting to follow. But it shows how we work in our own clinical practice. That this influences how I take care of patients and work with them. So.
Yeah, and so when you catch people with primary infection, you're setting them up for maybe a better overall long-term outcome, and also you're maybe helping prevent HIV right in that moment by sharing that information with that patient. If you're able to catch people who have while they're in primary infection. Anything else that you wanted to add or say about anything?
This is no. Thank you for asking questions.
Thank you so much. We really appreciate it.
Okay, no problem.
Thanks,
Yep.
Tim.
Okay.
Great. Thank you. That was so great. You're great at this, just so you know, because it comes
Oh, really?
out.
This is